Hello everyone, I'm back with cellulitis treatment. This is part 2 of my video which I've posted previously. So, how do we treat cellulitis in primary care setting? So normally we do conservative measures. For example, for pain and fever, we prescribe paracetamol, ibuprofen. We always check the hydration status of the patient. If there is any swelling in the legs, we tell them to elevate their legs. Don't stand for too long. Avoid compression garments. For dry and cracky skin, they can have emollient, which are easily available over the counter in the UK. Treat underlying risk factors. We can also go for non-adherent saline dressing to prevent infection, depending on the case. And if patient is obese, then we always consider weight management plan. So when you are dealing with pediatric group, which is a very sensitive and vulnerable one, so always follow your trust guidelines. NHS trust guidelines, look for BNF for the appropriate dosage, and always concerned with the senior if you have any questions regarding it, because underdosage or overdosage can create different consequences in this group. So be careful. So what points to consider when choosing antibiotics? You will be looking the severity of symptoms, the site of infection, risk of uncommon pathogens, for example, waterborne, previously microbiological result from the swab, and patient's MRSA status. Next. The treatment of cellulitis in children as well as in adults is flucloxacillin. Flucloxacillin is the first choice. We give it for 5 to 7 days. In the table you can see the dosage according to the age, starting from 1 month to 1 year is 62 to 125 milligram QDS, and we increase it to 250 to 500 milligram QDS for 10 to 17 years. What is the choice of antibiotics? In some cases, if flucloxacillin is unsuitable, then we can choose coamoxiclav for 5 to 7 days. For dosage, you can always look for BNF, Pete's BNF. If patient is penicillin allergic, then we give clarithromycin for 5 to 7 days. Here you can see the dosage of clarithromycin, which is mentioned here according to the weight and age. So under 8 kg, the dose is 7.5 milligram per kg twice daily. You need to do a bit of maths, accurate maths, so that we can give a nice dose to the children. And in the age group from 12 to 17 years, the dosage 250 to 500 milligram BD. When the infection is near the eyes or the nose, these areas are very sensitive, so always consider seeking specialist advice, cover it with antibiotics, add metronidazole if anaerobes is suspected. So for neonate, the dose of metronidazole is 7.5 milligram per kg BD. From 2 months to 11 years, dose remains the same, but we will give it 3 times in a day. From age 12 to 17 years, this is 400 milligram TDS. When I can refer my patient or admit my patient with cellulitis, if condition gets worse, for example, if patient comes up with necrotizing fasciitis, orbital cellulitis, osteomyelitis, sepsis or septic arthritis, vital signs are impaired, having comorbidity, life-threatening infection due to vascular compromise, or if the patient is severely immunocompromised, then these are the pointers which help us to think that we have to refer the patient or admit the patient. So well done, we have treated our patient with cellulitis with antibiotic coverage. What left is patient safety netting and safety advice. So always tell the families and parents or caregivers about the side effect of antibiotics. Tell them the skin will take time to return to their normal situation even they finish the course of antibiotics. If condition does not get better or if it is getting worse, then they should seek further medical advice. So yeah, that's all. And you can also give them patient leaflet, which I have mentioned, I think. Right, that's all done. And thank you so much for listening. I hope this video as well, you will find it useful. And I will post a new topic in upcoming days. And until then, take care of yourself. And if you have any comments, please come forward. I would love to hear. Thank you so much. Bye.